Good afternoon, good morning, wherever you are in the world. Welcome to the latest in CubTech Medical Education Seminars. My name is John Leach. I'm Vice President of Marketing here at CubTech. We are delighted to have our guest speaker with us today, Dr. Rachel Jendro, who is a surgeon at the Lincoln Surgical Hospital in Lincoln, Nebraska. Dr. Jendro, good afternoon.
Good afternoon. Thank you so much for having me.
Thank you for agreeing to talk to us today. Dr. Jendro will be presenting on the use of 3D tomosynthesis to assess surgical margins in her breast practice at the surgical hospital. And particularly, she'll be focusing on the journey from 2D imaging to 3D, some of the benefits that she's found of using the technology, and some really interesting case studies. So Dr. Jendro is with us live. What we're going to do with this presentation is we have pre-recorded it in the interest of maintaining content and keeping to time. After we've shown the recording, Dr. Jendro will be here to answer any questions you have. If you look on the right-hand side of your screen, you'll see a gray pane, and one of those things says questions. If you have questions, please feel free to type them in, and we will address those questions at the end of the recording. So please stay to the end to hear the questions all being answered. So with that, I am going to ask Dr. Jendro to turn off her camera and turn off her microphone, and we will please, CubTech team, run that recording.
Hello. So thank you so much for having me today to speak about the CubTech Mozart system. So this presentation is utilization of the CubTech Mozart 3D tomosynthesis system for margin assessment. So I'm Dr. Rachel Jendro. I'm a fellowship trained breast surgical oncologist, and just a little of my background. So from Kentucky originally, and went to the University of Kentucky, where I received my Bachelor of Science in Biology. Then went on to the Kentucky College of Osteopathic Medicine. From there, I completed my general surgery residency in Dayton, Ohio, and this is at the Grandview Medical Center. And just fell in love with breast surgery and knew that that was my future. So attended a breast surgical oncology fellowship at the H. Lee Moffitt Cancer Center and Research Institute in Tampa, Florida. And so after fellowship, I went on to join a practice in Raleigh, North Carolina. This was in 2013. So this was the University of North Carolina Rex Hospital. At this hospital, they had the CubTech system in place, and it was the older model, the 2D CubTech system. So I've been using that for at least 8 years there in North Carolina. My family and I decided that we needed to move from North Carolina to a different place, and there was a job opportunity in Lincoln, Nebraska, and they did not have a breast surgical oncologist in town. So it was a definite need, and it was exciting to come to this community to help really advance their breast care and help these women. So I joined General Surgery Associates, which is a private practice, here in April of 2021. The several hospital systems here in town use a lot of different intraoperative imaging systems. Some don't have any type of intraoperative imaging, so it was, interesting just to help them kind of get started and figure out what they needed to do for their breast program. So Lincoln Surgical Hospital is a surgery center here in town, and they just asked me, we do not have an intraoperative system for imaging. What would you like to have since you'll be coming here to operate? And of course, the best system on the market is the CubTech Mozart Specimen Tomosynthesis system. So this is the system I requested. So the hospital investigated this product, really saw the value, and purchased this 3D system for their operating room. So this is the first and only Mozart specimen system in all of Nebraska. So it's just super exciting to bring this to Nebraska and really just help these women have the best possible care. We know that the Mozart creates 3D images of our tissue specimens in 1 millimeter slices. So it is just next level imaging for our specimens. And this allows for more accurate intraoperative margin assessment. And the whole point of intraoperative assessment of these margins is to lower our re-excision rates. When dealing with breast cancer, we see invasive carcinoma and ductal carcinoma in situ. The standard of care is to have no tumor on ink for your invasive cancers and a 2 millimeter clear margin for your in situ carcinomas. So that's always what we're looking for. The goal of achieving these appropriate margins, again, is to decrease the recurrence risk for our patients. So the patient's going to have a better experience with their cancer journey. They will have a decreased breast cancer recurrence risk and a better long-term outcome. And this should always be our goal, is to take the absolute best care of our patients. So we'll go through a couple of cases where the Mozart was used and just discuss those specimens and the images. Our first case is KR. This is a 71-year-old female. She had presented with an abnormal right mammogram. The abnormality was identified through her screening imaging. She had denied any bilateral breast masses, any skin changes, or nipple discharge. Her only history was a prior cyst aspiration in her breast. Her mother and her maternal cousin had breast cancer. She had 2 children and did not breastfeed. She's postmenopausal and had never used hormone replacement therapy. So, we're always looking for these key factors to tell us who is at an increased risk. So on her 3D screening mammogram, which was performed in August of last year, this showed new calcifications in the upper inner right breast and was given a BI-RAD 0. She was, of course, brought back for additional imaging. She had a right diagnostic mammogram on August 27th. This showed a heterogeneous group of calcifications in the 2 o'clock position, which measured 5 millimeters, and biopsy was recommended at that point with a BI-RAD 4. She had a right breast biopsy performed, which showed atypical ductal hyperplasia. So we discussed that atypical ductal hyperplasia is not a carcinoma. However, it's a risk factor that shows she is at increased risk for developing a breast cancer in the future. The standard of care for these atypical lesions is a wide local excision to rule out an associated carcinoma. And most of the research on these atypical cells do show that there can be a 20% upgrade rate to a carcinoma on that final excision. Now, to localize these areas, there's a few different methods that I use. We definitely have advanced from wire localizations. I use 2 different methods here in town. One is I-125 radioactive seeds. I've been using the radioactive seeds since probably 2015. Fantastic system. These are to mark our non-palpable breast lesions. The probe, as you see in the picture there, is used to identify these seeds in the operating room. So one thing that's great about this system is there's no extra capital that's needed in the OR. You already have your probe for your lymph nodes assessment. So use this probe and just switch the setting, and it will identify your I-125 radioactive seed. The seeds are placed similar to a breast biopsy, and they usually target the calcifications, the mass, or the clip that's already there. And you can see in the left of your screen, the patient had at least 2 seeds put in there to identify the lesion. On the right, these will be your standard 2D specimen images, and you can see the seeds right next to the clip in those specimens. And again, showing needle placement of that radioactive seed and a specimen radiograph of the seed. Another localization device uses radio frequency for identification. This does require purchase of a extra piece of equipment to identify this in the operating room. So each tag has a unique identification number that's displayed on your probe when you're identifying the tag. So in the hospitals, usually the seeds can be used, and in the surgery centers, the tags are typically used. And this is just an image of a tag on an intraoperative specimen radiograph. So this patient was, of course, operated on at Lincoln Surgical Hospital, which is an outpatient surgery center, and she was scheduled for a tag localized excisional biopsy. And during the surgery, her tissue specimen was placed in that Mozart specimen tomosynthesis system. This is her image, and we can see the tag is the larger in the specimen, and her clip is that smaller piece there. And we'll go ahead and scroll through her images. So as you can see, these are 1 millimeter slices. And what's so great is that the cup tech is going to tell you what slice you're on as you're going through. You are really able to assess that anterior and posterior margin. Your typical 2D image radiograph is going to show you your lateral, your medial, superior, inferior pretty well. However, you just cannot assess that anterior and posterior. So this is just a fantastic way to show you how far those clips and tags or seeds are from your anterior posterior margins. So you can see here that the tag and the clip are pretty much in the center of our specimen. With atypias, we don't need extra margins at the time of surgery. So that's one thing to note with her being an atypical hyperplasia. So on this patient's final pathology, this showed atypical ductal hyperplasia with no malignancy identified. So the discussion with this patient is that, we can be at increased risk now for a future breast cancer. So for these patients, I always perform a Tyrer-Cuzick risk assessment, and it's just an example there on the screen to show kind of things that this assessment will take into account. This patient showed that she had a 15.3% risk of developing breast cancer in the next 10 years, and her lifetime risk was 21.6%. So the 15.3% risk at 10 years is a pretty significant number. So we need to talk to her about, what can we do to help decrease her breast cancer risk? This is just another slide showing how those numbers come out. On the right side of the screen, this assessment will also give you an idea of their risk to have a BRCA gene. So it's also something we can discuss with the patient. So, we discuss increasing her imaging to twice a year, alternating mammograms and breast MRIs. We also discussed taking anti-estrogen therapy, and this is, tamoxifen, Arimidex, different options there, but this could decrease her risk by more than 50% for a breast cancer, which is quite significant. I typically will discuss with these patients the option of a prophylactic mastectomy bilaterally. This patient was not interested in surgery, which is completely fine. It is the patient's choice always. So for her, she chose to take anastrozole, and this was prescribed by her medical oncologist, and this will significantly reduce her breast cancer risk. Other things to discuss with our patients are lifestyle modifications. So we know that, no tobacco, minimal alcohol, being at our ideal body weight, eating healthy, daily exercise, all of these things will help decrease their breast cancer risk. So we have to take care of our whole patient. Our next case is AS. This is a 77-year-old female. She presented with a new right breast cancer, again found on her screening mammogram. She had denied any changes with the breast, no breast masses, skin changes, nipple discharge. She had a niece and a first cousin with breast cancer. She was postmenopausal and had used hormone replacement therapy for 5 years. For her imaging, she had a bilateral 3D screening mammogram in September. This showed a vague density in the lateral right breast, and then a normal right breast was given a BI-RAD 0. Her right 3D diagnostic mammogram and ultrasound were performed in October, and this showed a 7.5 millimeter solid process in the 8 to 9 o'clock position. 4.5 centimeters from the nipple. This was given a BI-RADS 4 and a biopsy was indicated. Her right breast biopsy revealed an invasive ductal carcinoma. It was a grade 1, estrogen positive, progesterone positive, and HER2 negative. She then proceeded with an MRI, a breast MRI. This showed that the left breast was normal, no issues on the left. Lymph nodes in the bilateral axillae were also normal. And then the cancer measured 1 centimeter on the MRI in the 8 o'clock position of the right breast. She had a 4 millimeter focus of a low-grade enhancement, about 8 millimeters medial to this known malignancy. So this was definitely being able to be encompassed in a lumpectomy, and this was given at BI-RADS 6. You know, we always discuss all of their imaging and pathology in great detail. We go over all of the surgical options. So every patient should know all of their options. You know, this patient has the option of a lumpectomy, a mastectomy without reconstruction, and a mastectomy with reconstruction. It's so important to explain to them that there is no difference in survival among these surgical options. So this patient opted for a lumpectomy and understood that she would require radiation therapy after surgery to decrease her recurrence risk. So she was scheduled for a right breast tag localized lumpectomy with a sentinel lymph node biopsy. And during surgery, we again placed her surgical specimen into the Mozart specimen tomosynthesis system. This is the image that starts out. This is our optical image. And again, to play through what these images will look like, again, we can see the tag, our larger piece there, and then the coil clip next to her tag. And again, just to be able to see slice by slice what your image looks like is just amazing. And it's so much better than our prior imaging. CupTech has just made a huge difference in the specimen imaging. Just to see those margins, you can see there's a few calcifications there in the superior aspect to the tag there. You can see that your clip and your tag are right in the middle of the specimen. It's just amazing to be able to see that while you're in the operating room, be able to pivot, make adjustments, know how to best take care of the patient. So I did take margins all the way around the cavity with her, and her final pathology had showed a 2.6 centimeter invasive ductal carcinoma. It was grade 1, again, estrogen and progesterone positive, HER2 negative. She did have 2 lymph nodes removed, which were both negative for carcinoma. So this patient had a stage of a T2N0 1A. Her 6 additional shave margins were negative for carcinoma. So I did take all 6 margins around, and that's pretty standard practice for me. You know, individually, everyone has their own practice, but I typically take all margins. This patient then completed a 2-week course of her radiation therapy and is currently taking an aromatase inhibitor to again decrease her risk of a recurrence. So, you know, this Mozart specimen tomosynthesis system is so helpful to surgeons to help us to be more accurate in the operating room by assessing those specimen margins in a 3D fashion. So this, no one else is doing this. This is just state-of-the-art, amazing imaging that we have now. The system can also help our patients have better outcomes by decreasing those re-excision rates. And, you know, anything we can do to help that patient get through their cancer journey a little easier, we should do that. So it's all about our patients, and this helps us care for our patients better. And thank you guys so much for having me. I really appreciate being here.
Okay, thank you, Dr. Jendro. That was very informative. Could I ask you now, please, to turn on your camera and your microphone, please? There she is. So a very, very interesting presentation. We have a couple of questions, and I'd like to kick it off, actually, because first of all, how many surgeons at your hospital use the intraoperative imaging, the Mozart system?
I would say 2 to 3 breast surgeons are mainly at that hospital, Lincoln Surgical Hospital.
And one of the things that surgeons have said to me is, well, isn't this difficult to interpret? I'm used to seeing one image and you're going to give me 30. How easy is it to actually adopt the technology, learn it, and to use it effectively?
Oh, it's definitely, I think it's very easy to use. It's so much better just to be able to have that imaging in the OR with you, place your specimen there. Takes a few seconds for it to kind of read what your millimeter depth is, and then just go through those 1 millimeter slices. So the imaging is just so much better to assess all of your margins. I think it's very easy to adapt into a practice for sure.
Yeah, I think there's a perception sometimes that tomosynthesis is for radiologists. It's not really for surgeons. That you don't seem to hold that view.
I think surgeons can do anything. No, it's quite easy to use, and it does make us better. It definitely helps our patients for sure.
Yeah. Could you, the most important benefit, if you had to quantify one thing, what would it be from moving from 2D imaging to 3D?
To be able to see on that one specimen, we could see those calcifications right at the superior edge, and to see how far that was from your edge, and then knowing that your anterior posterior is clear. And the most significant impact that this has is getting that final report back after you've known what extra margins to take, and being able to call your patient to say, we have clear margins, all cancer has been removed, and we don't have to go back for a second procedure. That's, being able to give the reassurance to that patient and take that just weight off of their shoulders that we got everything, we're good. That's the most amazing part of this.
And do you feel that that's made a quantifiable difference? Could you measure and say, well, since we incorporated this technology, we've seen a change in the frequency with which we have to have that conversation?
I would say it definitely could make a difference. For my practice personally, I am typically take all margins anyway. However, to know how much margin to take is definitely going to help with that system. So it is quantifiable that you can know how much margin you need to take extra.
So does it help you direct any margin shaving you have to do, that it confirms that you maybe need to take more tissue on this quadrant than on others?
Right, absolutely. So if you know that you're only a millimeter or it's very close to that anterior, we know we need to take a little bit more generous margin on that side. So it definitely helps you assess during the surgery intraoperatively.
Yeah, yeah. Do you notice any time savings because it's taking the guesswork out of margin shaving?
I would say time saving, not necessarily, but just to have the reassurance that you can see what you need to see and take extra and even more generous if needed to. That's the huge reassurance there. It's wonderful.
Yeah. And do you do other surgeries other than breast, or is that your specialty? You just do breast?
No, yeah, breast surgical oncologist, so all I do is breast surgery.
And what's your caseload?
Oh goodness, but over 300 a year for sure.
Oh. And that's just you, and are you the main breast surgeon in the hospital?
I am, yeah, I was the first breast surgical oncologist hired in the whole town of Lincoln. So it's been amazing, and have gotten busy very quickly, as you can imagine. And it's been such a need in the community, and so welcomed here. It's been just wonderful.
So you successfully convinced the hospital to make a major investment in capital equipment.
I did, right away.
Yeah, exactly. Surgeons often say, well, this is great, but my hospital would never buy one. They don't have any money. How do you overcome that? Every hospital has money. How do you make sure you get it directed towards what you need?
One thing that benefits the hospital is that they can market themselves to say that they have this equipment, which is state of the art, top of the line, better for the patient, and patients will want to go there. So we've seen that, Lincoln Surgical Hospital has marketed this system, and patients will come into my office asking me about it. So they say, I want to go to that, where you have the Mozart 3D system there. So it's a big bonus for the hospital too, just to market that, they're top of the line, have the best equipment.
Yeah, I mean, we see this very often with hospitals talking about their breast center, how they employ the top surgeons and use the best equipment. And you're using that as part of the strategy by having the best equipment in the OR.
Absolutely.
Let me see, I'm looking. looking for the questions as they come in here. So the question was, I think you've answered, is what is the learning curve like going from 2D to 3D? Do you use the image blender on the system?
We do, yes. Use
And
all of the features there. It's wonderful. I mean, I would take maybe a couple of cases to get used to it. It's a very easy learning curve for sure.
do you ever use voice control?
We haven't set that up. I want them to set it up, but they haven't set it up yet on the system.
So this is just for people who are listening or participating in the webinar. The Mozart system operates under voice control. So you don't actually have to touch the system in order to bring up the images and to zoom in and zoom out and magnify. It's very useful. If you use Siri or Alexa, you can do exactly the same thing on the Mozart system. I'm trying to draw the questions here. How long does it take you to make a clinical conclusion or decision from intraoperative imaging?
I mean, just a few seconds. You know, you saw how fast it goes through your millimeter slices. Takes about 30 seconds to go through your entire specimen. So you can see, okay, we're a little close here. Let's take a little extra. It's very quick from, you know, assessing your margins, taking your extra margins based on the image. So it's very quick.
Yeah, because I think that, again, tomosynthesis, people tend to think it takes a long time, but of course it takes 30 seconds to get your image and run it.
Yeah, it's very quick.
What do you enjoy most about the experience using the Mozart system?
The clarity of the image is amazing. Just to see how far that CupTech has come and that they can do this and give you that type of clarity. I mean, you could see those little fine calcifications. That's amazing to even see the fine calcs in a specimen, much less to be able to see how close you are by scrolling through that image to assess your margins. The clarity is just amazing. Like it's impressive for sure.
Great, thank you. Here is a very practical question. What do you place the specimens on? Telfer or something else?
So some places will have like a grid that you can place it on and place it inside on a grid. A lot of times we use, you know, when you have on your sterile gown, the card that you pull off to tie your gown with, we'll just set it on the card because it's a nice little, you know, kind of a little bit cardboard piece and you just set it right into the system. So we'll use our gown cards a lot of times.
Yeah, and you find it simple to place the specimen in the right position on the detector?
Absolutely, it has markings inside that you can see and you just lay it and it tells you right where your center is. So they make it very easy.
Okay, can you talk a little bit about challenges that you might get in the surgical environment around DCIS?
So, you know, DCIS is always a challenge for margins. It seems like your invasives are so much more contained, and then your DCIS kind of tracks out and you've got skip lesions, and it's just harder sometimes to get those clear margins. But that's one thing that makes the 3D imaging so wonderful, is if you're targeting calcifications, which is, you know, a lot of times what DCIS will present as is calcifications. You can really see those calcs on that image and then scan through it and see right how, you know, exactly how far you are from those margins. So with DCIS, it's wonderful. So you can see those calcifications so clearly, you know, much better than just the 2D image. So I think it helps a lot.
Okay. Do you ever use intraoperative ultrasound?
I do, yeah, I do that a lot. On images that, you know, you can see by ultrasound, then I'll use the ultrasound in the operating room to target those lesions. Absolutely.
Excuse me, peering at this, the text on these questions is tiny, and I'm trying to read. Are there any other questions? I'm going to go back to our audience now. This could be your last chance to ask questions from our excellent presenter, Dr. Rachel Jendro. Let's have a look. Here's one here from. Okay, what do you use as your distance for clear margins? You say tumor on ink in pathology, but when you're actually in the middle of the surgery, you can't gauge tumor on ink. So what do you use as your safe distance?
I usually take a centimeter. You know, if it's not going to leave a cosmetic defect in the woman, you know, you always need to make sure you're assessing your cosmetic outcome. But you know, a centimeter is usually pretty safe.
Okay. Do you have a typical type of biopsy clip that your hospital uses? Do you mix localizers with wires as part of your practice, or do you always standardize on the same thing?
Yeah, I do not use wires. So just those two methods that we had mentioned, the seeds and the tags, are the two localization methods that I use for all non-palpable lesions. It seems the hospitals here use hydromarks a lot, so that's something you can see under ultrasound.
Yeah.
In the office, when I do biopsies, we've got some barred clips that we'll put in.
Yeah. Do you have any feeling for how often your intraoperative judgment of margins correlates with what final pathology actually say?
It seems like that taking those, I always take extra margins. I just do, because I just don't want that patient going back to surgery if we can help it. And it seems like you're surprised a lot of times of how close you are and to what the actual the picture is showing you. So I will typically, on the more conservative side, of taking that little bit of extra and trying to get that extra centimeter around, just to have reassurance that we've gotten everything, because it can be very hard to judge that.
Okay. That looks like that's our last question. So what I am going to do is to thank you very much, Dr. Jendro. That was a very interesting, informative, expertly delivered presentation. Thank you very much for your time. On behalf of CubTech and on behalf of everybody who's attending this webinar from all over the world, thank you once again. I am now going to close the webinar. Thank you everybody for attending.
Thank you.
Thank you.